The physician performs these procedures to promote healing of a fracture that fails to heal. Repair non-union, metacarpal, or phalanx, includes obtaining bone graft with or without external or internal fixation. The physician makes an incision overlying the dorsal aspect of the fracture of the digit. The extensor mechanism is retracted and the fracture is exposed. Surgical resection of the non-union itself may be performed. If this resection takes place, fibrous tissue must be removed until there are freshened fracture ends. If a resultant gap produces unacceptable shortening, fixation such as Kirschner wires or pins, or AO plates is applied. The physician closes the incision with sutures. Repair of non-union or malunion, humerus, without graft, e.g., compression technique, etc. With iliac or other autograft, includes obtaining graft. Repair of non-union or malunion, radius or ulna, without graft, e.g., compression technique. With autograft, includes obtaining graft.
Repair of non-union or malunion, radius and ulna, without graft, e.g., compression technique. With autograft, includes obtaining graft. The physician exposes the non-union or malunion of the humerus/radius or ulna by making a 10 cm to 15 cm longitudinal incision through the skin, fascia, and muscle over the fracture site. For radius and ulna, one incision is made on the lateral aspect and one on the medial aspect of the forearm. With the reciprocating saw, the bone is divided through the non-union.
The fragments are aligned. A compression plate is centered over the fracture and screws are inserted. A bone graft is needed to help heal the fracture due to bone loss. The physician uses an osteotome to harvest strips of bone, which are placed around the ends of the humeral fracture in addition to the compression plate for internal fixation. The incision is repaired in layers with sutures, staples, and slash or stri strips. The limb is immobilized. However, the deep facial layer is not closed because of the potential to develop compartment syndrome. A long arm cast is applied with the elbow in 90 degrees of flexion. Repair of non-union of carpal bone, excluding carpal scaphoid, navicular, includes obtaining graft and necessary fixation, each bone. An autogenous iliac bone graft is typically used for repair, which is obtained through an incision over the iliac crest. Once the bone is exposed, an osteotome is used to harvest strips of bone. These strips are placed between the carpal bones of the fracture through a 2 cm incision made at the base of the involved metacarpus. The physician centers a compression plate over the fracture and inserts screws. Lunate fractures require a short arm spica cast or splint with thumb immobilization. Fractures of the pisiform can be immobilized with a volar splint. Injuries to the triquetrum are best treated with a sugar tong splint. Treatment of a hamate fracture involves a short arm cast with the 4th and 5th metacarpophalangeal joints held in flexion. Repair of non-union, scaphoid carpal, navicular, bone, with or without radial styloidectomy, includes obtaining graft and necessary fixation. The physician makes a 4 cm to 5 cm longitudinal incision along the radial border of the flexor carpi radialis tendon to expose the fracture site. The capsule is divided longitudinally, and the underlying ligaments are retracted. An egg-shaped cavity is created in the fracture fragments. A cancellous bone graft is obtained and the graft is jammed between the fragments as they are distracted. The physician uses internal fixation such as a Kirschner wires to affix the bones if instability exists. If a radial styloidectomy is performed, the physician makes an incision on the radial wrist at the base of the thumb. Radial styloid bone is removed. The physician closes the incision, S, with sutures. Repair of non-union or malunion, tibia, without graft, e.g., compression technique. With sliding graft, the physician makes an incision on the medial aspect of the tibia through the periosteum. The bone is divided by transverse cuts and the pieces are manually rotated into position and stabilized with a metal plate and screws. In 27722, the physician makes an anteromedial incision and fibrous tissue is removed from the site. The ends of the fragments are roughened and the distal segment is hollowed out. A rectangular window is cut into the bone just above the site, cancellous bone is removed, and placed around the fixation site. The wound is closed, dressed, and a cast is applied. Repair of non-union or malunion, tibia, with iliac or other autograft, includes obtaining graft. An incision is made in the skin overlying the tibial fracture site. The incision is extended to the bone. The physician identifies the fracture or malunion. Any scar tissue is debrided from around and between the fracture pieces so that the clean edges of bone can be approximated. A bone graft is harvested through a separate incision from the patient's ilium or from another bone. The physician repairs the surgically created graft donor site. The graft is placed at the fracture site and the fracture is manipulated into the desired position and alignment. The physician applies fixation, such as screws, plates, wires, or rods to stabilize the fracture. The wound is irrigated with antibiotic solution and closed in layers. A splint, brace, or cast may be applied. Repair of non-union or malunion, tibia, by synostosis, with fibula, any method. Repair of fibula non-union and/or malunion with internal fixation. An incision is made in the skin overlying the fracture site. The physician extends the incision deep to the bone. The fracture or malunion is identified. Any scar tissue is debrided from around and between the fracture pieces. An osteotomy of the bone is performed if needed to correct the malalignment. Using the adjacent fibula as a strut, the fibula is attached to the tibia with fixation, such as plates, screws, or wires. This attachment allows the fibula to heal to the tibia in a synostosis. The physician irrigates the wound with antibiotic solution and closes it in layers. A brace, cast, or splint may be applied. Repair of non-union or malunion, tarsal bones. If the talus, articular surface, is involved, the treatment of choice is to fuse the talus to the tibia with bone grafting and casting. The same can be done for malunion of the calcaneus. In this case the calcaneus may be fused to the talus. Repair of non-union or malunion, metatarsal, with or without bone graft, includes obtaining graft. An incision is made on the dorsum of the foot parallel with the shaft of the affected bones. The old fracture is exposed and divided with an osteotome. A small portion of the bone must be removed to produce a non-union or division between the bone surfaces. The bone's alignment is corrected and stabilized with a medullary pin. The incision is closed with sutures and a cast is applied. At 3 weeks the medullary pin is removed and a walking boot is applied.